What I'd like to do in the next few minutes is give an overview of where things are at the current time in HPB and liver transplant training in North America specifically. I'll talk a little bit about some of the developments that the AHPBA has undertaken, especially in large part due to the strong efforts of Paul Gregg and Rebecca Minter and Rohan Jaraja, among others. So, can you advance the first slide? Things have changed pretty significantly in the last 10 to 15 years in the U.S. Prior to that time, historically, any general surgeon could perform HPB cases following general surgery training. A little bit different than for transplantation, that's always required some form of specialized training. General surgery training has changed pretty dramatically in the U.S. in the last 12 years, probably for a lot of reasons, but many would say as outgrowth of changes in new program restrictions and work hour restrictions that went in place in 2002. So what we've seen overall is a marked increase in fellowship training across a broad number of areas, including colorectal surgery, MIS, acute care surgery, and HPB. So why has that occurred? Well, I'll show you a little bit of data that's available. This is survey data of trainees finishing their program. This was undertaken and reported in 2008. Today, 80% of finishing general surgery residents in the U.S. complete some fellowship training. And many now, the newest trend is many are undertaking more than one fellowship after their training. There are a variety of reasons for this. The trainees have stated, among other reasons, their need for more experience, desire to learn in a specific area, and in some ways, a feeling of inadequate preparedness for, in this case, HPB surgery. In this same survey, 38% of finishing trainees did not feel confident in their skill level and had the sense that this additional training would make them more competitive. Many also favored the lifestyle of a specific training area. A separate survey reported in 2013 was sent to program directors about their sense of finishing trainees. In response to the question, can your trainees perform 30 minutes of independent work in the operating room and make progress in the case? 43% disagreed. In other words, finishing chief residents in general surgery today, the program directors felt, were not prepared to even continue 30 minutes of independent operating. Could their trainees take call at the completion of general surgery training with a rare need for assistant? 55% either were neutral or disagreed, didn't think they were prepared. So there's this feeling amongst trainees and the trainers that the candidates we're finishing after 5 years of general surgery aren't ready to undertake surgical care, including HPB surgery. All right, so let's talk a little bit about transplant training in North America. In liver transplant training, there's essentially only one way today, a little bit different than a few years ago, to complete training, and that's as part of an accredited ASTS, American Society of Transplant Surgery, 2-year fellowship. There's 62 programs and 73 positions. Many believe this is way more programs than we actually need, but that's what exists today. Programs are accredited by the ASTS every 3 years for liver and or kidney training. So as a program, you get certified as a kidney or liver or both program based on metrics including case numbers, which I'll show you in a second. Today, recent change, the ASTS is accrediting programs for HB or HPB accreditation. This is a new big area of interest. What in the past would be the ASTS, transplant training, really didn't have so much interest in HPB. Now there's a big shift and new interest in HPB training through the ASTS. So today there are 9 programs that have HB certification and 10 that have HPB. Programs can also get solid organ pancreas or small bowel certification. So that's the program certification. The trainees are certified. Programs are accredited. Trainees are certified at the completion of their fellowship. They are required to submit case logs documenting satisfactory completion of cases. There are new requirements for completion of web-based educational modules. Today, there are no exams. There is no board certification. This is an area of interest. The American Board of Surgery is interested in getting involved in this, and perhaps in the next several years we will have board examinations, written and possibly oral, to certify trainees at the completion of their training. All right, so what do we have today? Today there are 45 liver transplant programs in North America. There are 15 that have solid organ pancreas accreditation. As I mentioned, the HB and HPB, 2 years of training. So what's required of the trainee? Trainee, to have liver certification, must perform in 2 years 45 liver transplants, for pancreas 15, and be part of 25 organ recoveries. For the HB or HPB, I'll show you the HPBA's requirements in a minute, but for HB, 35 cases, of which 15 must be a hemihepatectomy or larger, 15 biliary procedures, total of 35. For HPB certification, 50 cases, basically HB plus 15 pancreas cases. Now there's some concern that the transplant tract for HB or HPB training, many programs may lack exposure to essential components of the oncology training. In other words, the trainees can be great technical surgeons, but surgical decision-making may be lacking. Multidisciplinary care involvement may not be there as fully as it should be. So what about HPB training in North America? Well, there are 3 ways that trainees can get this today. One is the AHPBA certified or accredited programs. Today there are 21 programs, 18 positions. Not all programs have candidates every year. This can be either a 1 or 2 year fellowship. The SSO, Society of Surgical Oncology, generally has 21 programs, 56 positions. This is usually a 2 year fellowship. And I've already mentioned the ASTS route. So what do we tend to see in terms of applicants? We have the 73 spots, 65 positions in transplant programs, but transplant training in the United States is very undersubscribed. There are every year about 40 applicants for those slots, about 20 of which are U.S. Graduates. So there's a large component of international graduates, but many programs don't even fill. The SSO slots, 102 applicants for these 56 slots. HPBA, 120 applicants for 18 slots. So when you look at that, in potentially 147 training slots, there are probably, Paul Gregg or others may know the numbers, there are probably 10 to 20 dedicated HPB jobs a year in the United States. So we're potentially training a lot of people. We don't really know the job market. It's hard to track these numbers. Many of these candidates will do HPB plus something else. All right, what are the AHPBA guidelines? So I've mentioned the ASTS, 50 cases. AHPBA, in terms of case numbers, 100 cases required for certification, of which for liver, 25, 15 hemihepatectomies, 25 pancreas, 15 biliary cases, and then the remainder rounded out with other case numbers. Pretty rigorous compared to the ASTS requirements. What about the SSO? Well, the SSO requires 150 cases, but says 15 need to be GI. Today, no specification of any HPB-specific cases. In general, the SSO has a broad focus on multidisciplinary cancer care. That's its big plus. There is perhaps some concern about the HPB focus for someone finishing an SSO fellowship to say, I'm ready to do HPB surgery. Now, there is overlap. There are some programs that have significant HPB experience and get dual certified. So you get your SSO certificate, you get your AHPBA certificate. And these include MD Anderson, Sloan Kettering, the Toronto program, and the Louisville program. There are many who believe the AHPBA fellowship bridges the transplant and SSO for HPB training. The requirements, I would mention, the Education and Training Committee of the HPBA really carefully regulates that. So there are two programs, the Toronto program and our program, that have the trainees get ASTS certification and at the same time receive AHPBA certification. So this is possible, but at the present time only two programs follow this route. There are some potential missed areas of training I would mention that I think are important at HPB training: robotics, MIS surgery, ultrasound, benign work, and non-operative management. So I think you could hopefully tell there is a huge range of training systems in North America. We believe these should be solidified and have common guidelines. Rohan Jaraj has worked for the past several years to set up a consensus conference to focus on what do we need in HPB training, to establish standards and maybe have common certification. This has been set up as a jointly sponsored conference between the AHPBA, the ASTS, and the SSO, and is going to take place on October 27th. We've just recently confirmed that date in San Francisco at the ACS meeting. The AHPBA has taken a strong stance in standardizing fellowship training with specific case log expectations, didactic programs, interactive grand rounds, fellows conferences. There are two held annually every year, a specific symposium at our annual meeting focused on fellow training, and a job site listing on the AHPBA. There's more to do, but a lot has been done. There are a lot of other areas that are in question, and perhaps Dr. Pinson will comment on other areas like, do we need an oral exam? Do we need a written exam? How do we certify accurately that our fellows have completed their training? What are the defined metrics? Do we do video assessment, for example, of surgeons to assess their technical skills? I want to just touch base a little bit on our program just as an example. We're here in the center of the U.S. We have 10 surgeons, 6 focused a little bit more on transplant, 4 focused on HPB. But it's a great team. Steve Strasberg is part of the group and has been heavily involved in our educational program. Dave Linehan, Magella Doyle, and others known to you here. So we have basically 2 pathways: an ASTS AHPBA certification pathway, 2-year track. We take one person for every year for 2 years, and we have a 1-year AHPBA HPB track. The transplant fellow and the HPB fellow rotate on both services. They're joint conferences. They swap. The Toronto program has a very similar arrangement. We think this works very well. We have a unique setup in St. Louis. I just want to mention that I think has helped our educational program pretty significantly. I think the bane of abdominal transplantation today is probably organ recovery. So this is something not very liked by anyone who has to get up in the middle of the night. And traditionally, transplant teams have to travel to procure organs. It's not safe. There have been 30 reported fatalities and 8 air crashes worldwide since 1990. The risk of dying in donor recovery is estimated at greater than 1,000 times that of a commercial flight. So in the U.S., we're in Region 8. Here in the center of the U.S., it's a very large 8-state area. The travel distances can be quite large. These procedures can be complicated. Brain death donors generate a lot of organs from a number of centers. You can have 5 different centers or more involved in organs coming from a single donor, but yet the brain dead donor receives very little priority. They're the first thing to get bumped. There's a trauma in the case. So there are frequent delays in workup and management, and this adds time to the trainee, who's often the person out recovering the organs. There are a lot of other disadvantages to the system that has historically been in place, including travel costs, ischemia time, etc. So in 2001, we set up a donor recovery center where we moved donors to our center. So this shows a heat map of 3 years worth of data of where our donors were located, that in the past we would have to travel to the donor center. Today we move the donor to St. Louis, and that includes by air transport. This is our recovery facility. In the basement is a intensive care unit, 3-bed ICU. It's pretty simple, but it will hold patients. This is the operating room. It's nicer than our operating room at Barnes Hospital. There are no delays. There is no other priority at that center other than donor recovery. This shows surgeon time for a case. If your recovery is at our center, under 3 hours. If we have to do a fly out, it's 9 hours if it's out of our region, just about 9 hours if it's within. These data were reported, they're coming out in this month's AJT. This saves a lot of cost. It's a big benefit to our center because the costs are much cheaper than managing and recovering a donor in acute care hospital. And our cold ischemia times are significantly shorter, especially compared to the national average for liver recovery.